So I have 10:05. I say we go ahead and get started. Welcome all of you. My name is Stephanie Almeida. I'm the Director of Learning and Development for the Southeast area. And it's my pleasure to welcome all of you here today to our training, supporting and treating the Hispanic community in a mental health setting. We have a great presentation lined up for all of you today. A couple of housekeeping. We do have ASL interpreters, so we do ask that one person at a time speak only, so that we ensure our interpreters capture all of the information, comments, questions during today's presentation. We're also going to ask that you put your camera off unless we are in one of the breakout sessions. That will also assist us with the technology in today's presentation. CEUs will be awarded for those that are interested in that. We are a very large group. We want to ensure that we have an accurate attendance of all that are attending today. If I could ask that participants put your name, agency, and your position in the chat, that would be wonderful. Speaking of the chat, we'll be using that as our main vehicle for questions, comments. Also today, I am assisted by Jonathan Fox. Thank you, Jonathan. Jonathan will be assisting me with the technology. You are welcome to reach out to Jonathan or myself anytime during today's presentation. We're happy to assist with that. I'd now like to introduce our facilitators, and I'm honored to do that. We have Dr. Gracia, the medical director from Brockton Multi-Service Center, also a psychiatrist. Our other facilitator is Dr. Momenti. So I'm going to turn it over to Dr. Gracia. He's going to talk a little bit about himself in today's presentation. Dr. Gracia.
Good morning, everyone. My name is Rafael Gracia. I am the Facility Medical Director at Brockton Multi-Service Center. I was born and raised in Puerto Rico. English is my second language, and Spanish is my first language. And I am very glad to participate today in our presentation about treating Hispanic communities. Luis?
Hi, my name is Luis Momenti. I'm a psychiatrist. I work at Brockton Multi-Services too. Dr. Gracia is my boss, and it's a pleasure to work for him. I was born and grew up in Argentina. English is my second language, Spanish my first. That's basically it. It's going to be a pleasure to give this presentation. And it's an incredible, this presentation is an incredible job by Dr. Gracia, together with Jeannie Crespi, Stephanie Almeida, and Jonathan Fox. Thank you, guys. It's really good.
Very good. Thank you both. So we have a great presentation lined up for you today. We will be doing a couple of breakout sessions. If you do need interpreter services, I do ask that you reach out to myself or Jonathan directly so that we can ensure that we plan accordingly for the breakout session. All right, so I'm going to go ahead and share my screen and we are going to get started. So Dr. Gracia, without further ado.
Okay, so today, we are going to be having some objectives for our meeting. The first one is to increase cultural competence in providing care and treatment in Hispanic community seeking services at the Department of Mental Health. The second objective is to describe the psychological effects of the path of immigration, including the 3 distinct stages and the impact the process has on immigrants seeking care and services. And our third objective is to familiarize ourselves with key cultural components of the Hispanic community and the impact that they have on mental health symptoms and treatment needs. So
So,
let's start with some facts and myths that we have prepared about our thoughts about what is a Hispanic community. The first one is Puerto Ricans need to receive a green card or visa to reside legally in the United States. Is that a fact or a myth?
Jonathan, whenever you're ready, could you please launch the poll? So everyone should be receiving a poll question. Please feel free to answer, myth or fact. I can assure everyone that responses are anonymous. So no worries if you're unsure. Please feel free to go ahead and respond. All right, it looks like most people have responded.
So very good. We have a well-instructed group. It is a myth. Puerto Ricans by birth are United States citizens and do not require a green card. We have a United States passport. And this is because of a Jones-Shaffer Act that was enacted by President Woodrow Wilson back in 1917. So for over a century now, Puerto Ricans have been American citizens. Our next myth.
This is a question basically to test your knowledge on the Hispanic-speaking countries. We have put 6 countries there, and the question is, which ones are not Spanish-speaking countries? If you want to give us the answers, then we'll discuss which ones and another couple of facts.
Looks like we're about halfway with participants giving their responses.
Are we set, Stephanie?
Yeah, it looks like just a couple more people. And Jonathan, I think whenever we're ready for the results.
Bolivia is a very interesting response. Nicaragua and Uruguay are definitely Spanish-speaking countries. Belize is an English-speaking country, and Brazil is a Portuguese-speaking country. Now, Bolivia is an interesting case because even though it was considered a Hispanic-speaking country, there are 3 official languages in Bolivia. The most popular, of course, is Spanish with about 65% of the population. Then you have Quechua, which is another language. And then you have another language called Aymara, A-Y-M-A-R-A, which they're all native languages. Aymara is a language that's spoken mainly in Bolivia, but also in Peru Chile, the northern part of Argentina, and the southeast part of Brazil, which is mostly jungle with very few inhabitants. Bolivia changed its name in 2009 from Republic of Bolivia to the plurinational state of Bolivia to accommodate the different ethnic groups and their particular cultures. That's just a detail, but it's important because it shows that there are other languages that what we consider at first Hispanic immigrants, they could speak other languages too. Thank you very much.
Thank you. All right. And our third fact.
Well, the question is Hispanic/Latinos are not a single race.
Looks like most folks have had a chance to respond.
Very good. So we have 72% that answered that it's a myth, and 28% that answered that it's a fact. Well, this statement is actually a fact. Hispanic Latinos are not a single race. As you will see by the next slide, we are basically composed of the mix of the European culture, which were the European settlers in America, the indigenous cultures that were present throughout Latin America, and the African culture that was brought in during periods of slavery, unfortunately, but that they were very quickly assimilated into the Hispanic cultures. Next slide.
So I'm going to turn it over to Jonathan, and he's going to pull up the slide. And I think our next thing is we're going to be watching a quick video.
In the meanwhile, I'd like to point out, okay, no, go for it.
So I met him on Bumble, and he was super nice, and we were texting all last night, and then he asked me how tall I was, and I told him, and then he stopped answering.
All right, well, that's your first thing. You always have to update your profile, keep all your info in there, because
One second, sorry. Bueno, hola, mami. No vi lo que pusiste en Facebook, ¿qué pasó? Mami, te puedo hablar al rato, estoy con una amiga. Okay, love you, bye. Sorry, moms.
I didn't know you were Spanish,
I'm not,
but you speak Spanish.
but I wasn't born in Spain.
Wait, what?
I'm Hispanic.
Oh, okay, I see. Or should I say, yo veo.
No.
You've got to be kidding me.
What's up?
I asked the intern to make 100 copies of this casting call and there's a typo.
Donde? I don't see a typo.
Look, they put an X at the end of Latino. Latinx?
It's Latin X. We should hire the intern.
I didn't know that was a thing.
Hey.
Sorry I'm late.
Oh, no problemo. I already got the tickets.
Problema?
What?
Never mind, let's just get in line. So, who's in this movie?
We got Ryan Gosling and that Hispanic actress from Homeland.
Morena Baccarin?
Yeah.
She's Hispanic?
Yeah, she's Brazilian American.
So she speaks Portuguese.
What's the point?
Technically, if she's from Brazil, she's Latina, not Hispanic.
Being Latina is based on geographic location, whereas being Hispanic is focused more on language. Someone can also be both Latina and Hispanic.
What would you call someone who's both Latino, Hispanic, and may or may not be a quarter Spanish?
A person.
Oh. I feel bad.
I think this is a good introduction to some issues that have to do with Hispanic culture, particularly the fact that in our language, Spanish, everything has a gender. So even a pencil, it's male, a table is female, etc. So that's why the A and O at the end of the words. The term Latinx was coined to include all genders. And it's interesting because in our discussions, one of the things that came up is that some people thought that Latinx referred to the Hispanic LGBTQ community. But when we use it, Hispanic people, we refer to everyone, no matter what gender. And it doesn't have to be necessarily because of the LGBTQ community. Also, I think it's very important what they say at the end. What do you call somebody that has all this mixture? It's a person. I think one of the things we want to convey today is that Hispanic culture is not a monolith. There are many different countries, many different languages, many different customs, and this creates a diversity that I think sometimes we don't take into account. So when we think approaching mental health for a Hispanic person, we might be thinking in a box about, okay, so this is the guidelines and this is how it is, but we really need to get to know the person first, because they might come from a culture that might not be something we really know as Hispanic. Let me give you an example. In the south west of the United States, the majority of Hispanics are actually of Mexican descent, versus Florida, where the majority of Hispanics are from the Caribbean, mostly Cuba. And then you go to the Northeast, and there's a large number of Puerto Rican Hispanics. The largest number of Hispanics actually in the United States are of Mexican descent, followed by Puerto Rican descent. So it could be many different cultures.
All right, so I think we're going to take a look at some demographics now.
So one of the demographics that we have here is about how the Hispanic and Latino population grew in the United States. From 2010, it was 50.5 million to 62.1 million in 2020. So that was an increase of over 2% in the amount of population that is Hispanic. And between 2010 and 2020, the Hispanic or Latino population grew basically by 23%. Slightly more than half of the US population growth came from growth in the Hispanic or Latino population. And according to the census projections, there will be more than 111.22 million of Hispanics in the United States by 2060. This helps explain why we see on the news how so often politicians are looking for the Latino vote, because that's going to comprise at least 1 in every 5 people in America are going to be considered Hispanic. Therefore, it has implications not only for politics, but also for economy. It's a large contributor to the American economy, the Hispanic population. In the Commonwealth of Massachusetts, we can see that there's a large number of Hispanic and Latino residents. By the way, one of the things that we say is that Hispanic, as you heard, is because of Spanish-speaking countries. Because of this, we would say, and we discussed it with Dr. Momenti, Latin America, basically everyone is Latino. So it's derived from a Latin language that includes Portuguese, French, and other languages, whereas not every Latino is Hispanic, but all Hispanics would be considered Latinos. And as you can see, in Massachusetts, as of the 2020 census, the Latinos or Hispanics accounted for 12% of the total state population. It's interesting when you look at the distribution by different cities. In Brockton, it's 11.88% of the population, whereas Lawrence, it's 81.9% of the population. So you see by this distribution that there seems to be a tendency of Hispanic people to try to stay together in certain areas. This slide again brings a point about in the Southeast area, what's the distribution of race in the population. As you can see, it says 5% in the Brockton area. In the New Bedford area, it's 29%. However, if you look in Quincy, there's a large part of the population that identifies as other. And one of the questions that we had when we started looking at this data was that I first said, why are we separating, as you can see, white Hispanic versus African or Black American Hispanic? Hispanics don't look at it that way. No matter the color of your skin, you're Hispanic. So what this leads to is that in the United States, a lot of the things that we do with census applications, etc., is that they're asking for race in addition to what's your ethnic background. So there's a tendency of a lot of people of Latino or Hispanic origin to identify as other, because we consider ourselves as a mixture of different races. So when we see this other, how many of those are really Hispanic? Because if you look, it would look like the Hispanic population in Queens is only 3%, but it might be larger than that because of this part that identifies as other. I think this is a very good slide to show us in terms of the general population. As you can see, all individuals served by DMH, 9.2% are considered to be Hispanic. In August of 2022, the DMH data said that of the people served, 12% were Hispanic. And of the ACCS, in the ACCS data, it was 8.2% of the people served were Hispanic. This actually brings up a very good point for all of us because it shows the different data on the people served by DMH, where 9.2% are Hispanic versus staff. And staff, we only have 5.2%, which would be less than half, more or less half of the general population represented in part of the DMH staff. This has implications that, as we will discuss later, in terms of how to engage the Hispanic community, it can be a limiting factor. Hispanic people may feel more comfortable when they can go to a place where they see people that they can identify with. And that's important of having a diverse workforce, not only being able to hire, but to retain people that belong to the different groups that we serve. In an ideal world, these two slides should look very similar and have very similar numbers. But when you look at it, you see that the ethnicity of the staff doesn't seem to be congruent with the ethnicities of all the people served. So then, when we talk about mental health, what are we talking about with the Hispanic community? Well, there's many different diagnoses. Again, it's people, and their diagnosis would be varied, just as they are diverse. You will see a lot of Hispanic community being treated for anxiety disorders, major depression, a lot of PTSD, as we will discuss later, dependent many times on the type of immigration that they had, issues with addiction, suicide. And the suicide, one of the interesting data is that it depends a lot on the stages of where people are in the process of acculturation. As people become more assimilated to the American culture, the rates of suicide in the Hispanic community increase. And of course, we have some clients here at DMH because we serve populations that have severe mental illnesses. We have people with mood and psychotic disorders. An estimated 33% of Latinx adults with mental illness receive treatment each year compared to 43% of the US average. So the question is, why is it that it's not the same? And there might be some limitations in terms of access, in terms of engagement. In a lot of Hispanic communities, it's still somewhat of a stigma to talk about mental illnesses. And it's part of the job that we have to do with the community to help fight that stigma so they can reach services.
The culture and mental health. All different cultures, they share the same mental illnesses. There is a difference, however, in some of the ways they express it. Some of the symptoms of the illnesses are different, tend to be different between the different cultures. For example, as DSM-5 states, in panic disorder, there are some culture-specific symptoms. For example, tinnitus, which is ringing in the ears, neck soreness, headache, uncontrollable screaming or crying. Those are symptoms that can be seen mostly in Hispanic culture. Those symptoms should not count as one of the 4 required symptoms for the diagnosis of panic disorder. We have to remember that the Hispanic culture, as most cultures called Latino cultures, and the name Latino cultures comes from the language they speak. Latino cultures are cultures who speak languages that come directly from the Latin language. That's why Latin America is called Latin America, because most of the people living there, their cultures and their languages descend from the Latin language. Those cultures tend to be, in general, a bit more expressive, let's say. They will let you know usually how they are feeling, and they are a bit more, I hate to call it dramatic, but that's how we are. We tend to speak more with our hands, and we tend to raise our voices in a non-threatening way. We say, oh, poor me. And that's me too. I mean, I'm very much like that in real life. So that's why it's different. More people from the Anglo-Saxon cultures, they tend to be more reserved. You cannot tell their feelings as much as you can tell us. They don't speak with their hands. They don't tell you, hey, I don't like you, or hey, come here. That's something that you have to take into account. However, the basic symptoms that you need to diagnose a determined illness or a determined disorder should always be the basic ones. You should take into account culture, but do not use those extra symptoms as part of your a requirement for the diagnosis. Use them as a guide, and also use them to understand and relate in a better manner to the people. Then personality disorder, an enduring pattern of inner experience and behavior that deviates markedly from the expectation of the individual's culture. That's what we were discussing just now. Personality is the way we relate to the environment. Is not the same as an illness. And that's where we differ, where the different cultures differ. Whereas I express myself more naturally, some of the other professionals here are more restrained in their expressive ways. Now, they'll come and they'll say, Luis, I'm feeling a bit upset, whereas I'll say, hey, I'm very angry, get out of my office. It's just examples of it. So that's all. We can go to the next one.
So this slide shows some of the cultural syndromes that have been identified by the American Psychiatric Association. You will find the link in the resources. But some of these cultural syndromes are things like ataque de nervios. That's something that it's used in Hispanic cultures, and it's a heightened state of anxiety that often results in a state of being sort of out of consciousness. And the important part is that it's perceived as being caused by external sources. So something it's causing the person to have the anxiety, rather than what we would call an anxiety disorder per se, which is something that we identify as an internal type of response. So in the Hispanic culture, it's looked at something that is provoked by a certain thing outside the person. We also have cholera, or ataque de cólera. That's a term that is interesting because it's generational. Cholera is, with an H, a disease that has outbreaks in Latin America often. And because of this disease, the use of this word has been reduced. But the original word, cholera, written without the H and with the O, meant about people that would get this type of rage attacks. And they would, because of the rage, they would get like all red and bent out of shape, and it would lead to symptoms like headache, screaming, stomach pain, loss of consciousness, fatigue. And it was, again, a very strong emotional response to events. Also in the Hispanic communities, we have something called mal de ojo. And mal de ojo is when people believe that certain problems that a person might have, physical problems, like vomiting, fever, diarrhea, and mental problems, are caused by somebody giving them the evil eye. We were in our discussion about this, I was remembering that one of the common things we used to give babies when they were born was that someone would give them a little black fist with the thumb between the fingers. And that was something like an we called it amuleto, which would be something that they thought would scare the evil eye away from the baby. They also have something called espasmo, or espanto, pasmo, susto, miedo. That's when somebody gets, the word in English to translate that would be spooked, basically, but it turned into the person having symptoms of tiredness and weakness resulting from the experience of being startled or extremely frightened. We also have what people call wind or cold illnesses. And it's a fear about cold things causing people to become ill. And sometimes it's included in there that there might be natural and supernatural elements that are not balanced. And this is what causes this type of chill or cold. I think in a certain way, this is not unique to our cultures. We were talking about an Italian culture, the evil eye, it's very prevalent, but again, we're descendants of European cultures that have that. And I think that you all remember in the movie Chocolat, when the main character, when there was a cold wind and they would go away because that would exemplify some kind of evil thing that they needed to move on. That is also seen. Other symptoms or syndromes that we have seen are things like people talking about espíritus or sombras. Espíritus is the belief in that there is a spiritual interaction with human beings. Some people talk about the influence of those spirits on people's health. And also in the sombra, sometimes it was the belief that if people see these shadows or saw the shadows, that it meant that somebody that they knew was going to die.
Next one. Types of immigrants. There are different types of immigrants as defined by the government, which is the one that makes this kind of definitions. For us, it's people that come from a different country to enrich us. But legally, you have different kinds. You have the US citizens who are US citizens by birth in other territories or by naturalization. Then you have the residents, which are lawful permanent residents or green card holders. It's a very valuable document that us foreigners, not Puerto Ricans, like Dr. Garcia told us, like us foreigners, all our lives, we spend it trying to get the green card because that's the magic solution to our problems. Then you have the non-immigrants, who are individuals of non-American nationality who have been granted temporary permission to be in the United States for a specific purpose. And they have non-immigrant visas. These are, for example, people who come here to get medical care. It's very common for people from other countries to come to the US specifically to get care for a certain illness. Of course, we are talking about the rich people in other countries. The poor people go to the curanderos. And then you also have the students who come on student visas, medical doctors who come here to do their residency and they are granted different kinds of visas. And all the people that are here supposedly for a determined amount of time. Then they can stay or not, but that's a different story. Then you have the undocumented, which are individuals who have entered the United States illegally and will not have any documentation supporting their stay. These are people, for the most part, who come from Mexico. They cross the frontier. Most of them come here to work. They do really difficult kinds of jobs, but they never get any recognition. So that's them. And then finally, you have the asylum seekers. People who are running away from certain things in their own countries and who come to the US in 4 ways. The affirmative merit interview, which is interviewing someone, and if they deserve to, they can stay. People who come here to set up industries, for example. Then you have the defensive, which is people who are here because they need to, and they need to stay because of different reasons. You have the special immigrant juvenile status, which is for unaccompanied minors. There's a lot of that recently. There are minors whose families send them here looking for a better way of life. And once they reach 18, many of them, not all, but many of them can get their green cards and then eventually their citizenship, and then they bring their parents. It's a very tough, it's a very difficult, especially for both, for the parents and for the minor, to let go of their children in that way, just to find a better way of life. Immigration, like Dr. Gracia is going to tell us with the next slide, is a very painful and very difficult process, which unless you've done it, it's very hard to feel.
And immigration as Luis mentioned, it's a process, and there are different stages of it. There's a pre-migration stage. This stage is when people are making the decision that they are going to leave their country, and they start preparing to leave. And this stage can be very stressful, involving losses, risk, probably consequences, both financially and safety at times. Remember, a lot of the people are leaving their extended families to try to look for a better life for themselves. So this preparation aspect of it can be very stressful. Then the following is a migration process itself, which is when people are traveling to enter the United States. And what does this journey involve? Well, it could be many different things. For people who come in with a visa, it just implies coming on a plane and meeting people here to work, for example, versus people that have to travel through several countries and jungles and fight gangs and violence and all these things to get into the country. So this process of migration can have very serious implications for mental health, because as you can imagine, it will be a completely different experience that can lead to trauma, anxiety, and other issues like depression because of the loss that we would address in mental health. Then there's a post-migration process, which is the stage where people are already in the country and they start the process of acculturation and assimilation into the new society. In this stage, you can see other issues emerging, like, for example, it's not uncommon for people to feel isolated during parts of this process, starting to have feelings of depression, having difficulties connecting. There might be difficulties with language and barriers. Sometimes people come to the country expecting things to be different. As you know, around the world, people think of America as the land of opportunity, and then they come in here to find that it's very hard to get a job. So these things can have an effect on individuals' mental health. And as we talked about process of acculturation and assimilation, there are two different things. And as you can see by the definitions, in acculturation, the process is cultural contact and exchange, and a person or group comes to adopt values and practices of a culture that is not originally their own, to a greater or lesser extent. In this process, acculturation, the result is that the original culture of the person or group remains, but it is changed by this process. First is the process of assimilation, which is a linear process by which one group becomes culturally similar to another over time. Taking this, one can see that generational changes within immigrant families lead to a process of assimilation in which the immigrant generation ends up being culturally different, and then the later generations are very similar to the people in the country. Examples that I was giving about that include things like, for example, foods. In the process of acculturation, it would be like somebody invites you to their home and they know that you're an American family. So what they do is that they have learned that the taste palette here in America is a little blander. So they serve you the same Latin food, but with less spices, so that would be appealing to you. That would be acculturation. Versus assimilation, which would be they invite you, and because they know that you're here from the States, they serve you meat and potatoes.
Now we go to understanding the Hispanic culture. Like we said before, the cultural history of many countries is very different. The multi-ethnic influences. You have anything from Mesoamerica, which is Central America, including the southern part of Mexico, which is a place where there were multiple local cultures. Then you have as you go down, those cultures begin to get less and less. And then when you get to the southern part of South America, where we have Argentina, Chile, Uruguay, part of Bolivia, those countries, there were no local cultures basically when the Europeans arrived. So if you go to a place like Central America, you're gonna see a mixture of the Hispanic culture with the local cultures. To a very, very high degree, the influence of the local cultures is very, very important in those countries. Then as you go south, once you get to Argentina and Chile, which is another country to the west, with whom we don't get along very well, but it is in a good way. Then you have there was no local culture. So Buenos Aires grew up just like European cities. They built it with the same blueprints. It's a big country, and yet in Buenos Aires, most of the streets are very narrow, because that's how they are in Europe. So that influence marks a lot of how they perceive healthcare. In Central America, they use a lot more curanderos, more of the traditional medicine that those civilizations had. Then you get to the southern part of Argentina, and Argentina is, as it was built the same as Europe, we always looked at Europe for an example of what to do. So the cars look all European. Psychiatry was not very popular. We used more psychotherapy, the psychoanalysis being the big thing. Freud was everywhere. You dropped a pencil and they would start analyzing what Freudian or trying to say what Freudian thought of why you would drop a pencil. It's changing a bit, but that shows you how they all view healthcare as a different entity depending on what mix or lack of mix of the culture is. First generations, when they come to the US, they, like you've seen, they go into groups. That's why certain cities have more Hispanics, because Hispanics, first culture, first generation, when there's no assimilation still, they gather together and they follow a lot of the customs that they have in their native countries. That changes over time as their children grow in an American culture. They become more used to that. That's what they hear in school. That's what they teach them. And they are not as afraid of the American way as their parents were, because their parents, when they came here, they are afraid of going to a doctor, because it's not easy for them to find Spanish-speaking doctors. So they tend to treat everything more at home or based on what Doña Maria, their neighbor, told them that they had done with their family. So it's a very interesting thing, but it changes as the generations of American-born keep progressing. There's also the socioeconomic level. The further you get away from the US, the less immigrants you have, because it's expensive to get from Argentina to here than it is from Mexico. So the people that come from countries like Chile, Argentina, most of them, like Dr. Gracia said, we get on a plane with our bags. If we can, we travel in business. And when we arrive here, there's somebody waiting for us. We arrange insurance. We are not afraid because down there we were in a good class, so society was good to us. And then you have the people that come from Mexico. They are very poor. They go through a lot of problems to get here. It's really very traumatizing. So that affects a lot how you get your health care. It makes a big, big difference. Jonathan, next one, please. Okay. Now, we have to talk about personalismo, which is in Hispanic or Latinos, the relationship you establish with the healthcare giver is more, trust is more important than in other cultures. In Hispanic cultures, doctors, nurses, therapists, they are seen as, especially doctors, they are seen as something between the gods and ourselves. So they put all your trust in you. If they like you, if they don't like you, they might feel differently and they might look for someone else. But once they trust you, they'll see you as kind of a very important guide in their lives. Whatever you tell them is gonna be held in very high regard by them. Familismo. Familismo is the role of the family. When you're talking about healthcare, you cannot talk about Latinos without talking about women. Women are the ones that coordinate the healthcare of the whole family. Their husbands, their children, if her mother or the husband's mother died, they take care of the surviving husband. They take care of their kids, their grandkids, and if they have great-grandchildren, of them too. The older women are the ones who will take the guiding place over the younger ones. And as they go, and as they die, the next one takes their place. So when you're dealing with healthcare, always make sure, if possible, to include mothers, wives, unless they specifically tell you, and then unless they say no, I prefer not to. But women take care of all the family health in general. Their own, when it comes to their health, they tend not to include other people except their daughters or mothers. But they take care of male members of the families, rarely take care of that. The males in the family are usually, since it's mostly a patriarchal society, males take care of the finances, where to go, what to do for a living. And even that, especially in countries in the southern part of South America, women are very happy to accept the role of housewife. That which doesn't mean they accept the patriarchal thing. They accept it in appearance, but their opinion in every family matter is of extreme importance. They take the role of that their mothers had as far as looks goes, but they are very, very influential, not only in the healthcare, but in also the regular decisions as financial or work-related of the whole family. They just let their husbands do the talking, but they are the ones who tell them what to say. So even if you think it's the male deciding, trust me, they're telling you what they were told at home. It's very common. Okay. Now we're going to talk about religion, spirituality, the influence of local culture, local beliefs. South America used to be 95% Catholic. The Catholic Church had a huge influence. And I know nowadays that would carry not always a positive connotation, but I'd like to mention that in most of South America, except for Brazil, it was the church who refused to have slavery. The church made a very, very strong case against slavery. And in Argentina, for example, or in Chile, Uruguay, there were never slaves there. The church said, if you bring slaves, you're going to jail. So in Argentina, you have a population that's about 95, 96% white. Mostly half of Italian and half of Hispanic ancestry. But we were never allowed, fortunately, to participate in that horrible practice. And that was due to the church, because the church said we are all the same. This is not happening. Talking about the spiritual world. In Latino cultures, having spirits in the house or spirits that talk to you is not something considered psychosis unless you begin to do very strange things, unless your behavior becomes very far from culturally accepted standards. I had a nurse who used to, when one of our relatives died, she always saw a spirit coming to pick them up. So when my father died, for example, she saw what she believed was his mother coming right at the moment he was dying to take his spirit with him back to heaven. Or wherever they were going. I mean, I'm not the judge in those things, so he was a great guy, but and yet she was not considered psychotic. That was just a normal expression in that culture. Like we said before, Latinos are more emotional, they are less scientific. Not too much, it's just in the way they behave, because we have great scientists too. But that part is the part of the emotional is much more relevant in the Latino culture than in others. That is something you have to take very, very much into account, especially in psychiatry, when you're evaluating a person from a Latino country. Dr. Garcia will talk to us a bit more in detail about that, because he knows all those things much better than me. I just do the basic thing and then he'll tell the goodies. That's about, and he also, and Latinos are much more prone to go to the, what here they call shamans. In Spanish, we also have the chamanes, but they're also called curanderos, which is not such a respectable connotation as shaman, but that they are very popular down there and up here too.
I think it's very important to consider again that these are not stereotypes. I know that, again, we have the tendency of try to think that, well, you know, all Hispanics will go to a spiritualist or a curandero. Not all Hispanic people will do that. Again, everybody's individual. There, even within certain places, like let's say in Puerto Rico, there are areas of the island where you are more likely to find people that believe in this kind of alternative medicine than in the urban areas where people follow a more traditional healthcare system. So these stereotypes are something that, we need to understand that they are there, but that they are not specific to everyone. And that's the importance of meeting people individually. Same thing with the religion part. Even though the majority of people in Latin America are Catholic, we still have people that belong to other religions. And in Dr. Malmenti's own country, there's a large enclave of people that fled Europe during the World War and are a large Jewish population. So you see somebody with a Jewish last name speaking Spanish, and again, we consider them Hispanic because we don't look at them as of race or where they come from, but they are part of our group, our social group.
We have, in the Northeast, we have a huge Jewish population, and then in the Southwest, we have a huge German population, which are Lutherans mostly. That also, they came, everybody, lots of people came looking for a place to be safe after the World War. Argentina took everybody in. We never discriminated. And that's why it's a very cosmopolitan and good place to live. But yes, these are just, not all Latinos are like me. Some are nice, some are like a bit calmer. But you have to be aware that you might run into certain traits more often than in other cultures, yes.
Very good. And I think now we're going to move to look at some case scenarios that will illustrate some of these points that we're presenting today. Stephanie?
Yes, thank you. So we do have two case scenarios that we're going to do this morning. I invite you to take a screenshot or perhaps a picture with your phone of the two case scenarios that we're going to be using. We will be broadcasting both case scenarios in the breakout rooms, but we found that that is easier. I'm going to ask that someone read this first case scenario for us. And I'm just going to pick someone randomly. Aruna, could you read that?
Sure. I don't know how to pronounce that name. Is it Jorge?
Jorge.
Okay. He's a 24-year-old doctor who graduated from a Hispanic country's medical school and was accepted for his internship in Harrisburg, Pennsylvania. During his first month of rotation in the ICU, he was noticed to be participating in rounds while tears were rolling down his eyes. His attending expressed concern to the residency director that Jorge may be depressed and showing signs of histrionic personality given his expressive gestures during discussions about his clients. The director of residency training called Jorge to his office. Jorge insisted he was not depressed and could not explain the tears. The director gave him the weekend off to call and get himself together, weekend off call to get himself together, and scheduled him for an appointment with an IEP counselor who happened to be of Hispanic descent. Does Jorge have a histrionic personality disorder? Is Jorge depressed? Is there anything else Jorge's director could have done differently?
Okay, very good. So again, if you want to take a quick screenshot or a picture of this with your phone. And we have a second case scenario. And Randy, could you read this case scenario for us?
Okay. Marcos is a 14-year-old youth of Central American descent whose parents immigrated from Nicaragua 2 years ago. His parents are primarily Spanish speakers, and Marcos often provides translation in accessing care and services. He is referred to DMH Children's Services due to behavioral disturbances in the home resulting in a recent inpatient admission. His parents report that they came to the US seeking economic opportunities and to escape instability in their native country. Question 1, are there cultural factors that may impact his access to care, treatment, and engagement in services? Question 2, what historical factors may be associated with Marcos' mental health symptoms and behaviors? Question 3, what strategies could be implemented in providing care and treatment for Marcos and his family?
Thank you, Randy. Again, if you, I invite you to take a quick picture or a screenshot of this. So in just a moment, Jonathan is going to be putting you all into breakout rooms. You will get a pop-up on your screen that will ask you to join. I do ask you to make note of the group number. Group numbers 1 through 4 are going to do case scenario number 1. Group numbers 5 through 8 are going to do this case with Marcos, case scenario number 2. We'll be broadcasting this in each of the breakout rooms, but again, we ask that you make note of the breakout session you are assigned to. So, Jonathan, whenever you are ready, please feel free to launch the breakout rooms. I see folks returning.
Wow, that was a trip.
There's the boss.
All right.
Yes. All right. So in terms of the discussion on the first scenario.
So how about group number 1? Because we are such a large group, how about if you give us, the top 2 or 3 things that you spoke about in regards to this case scenario, and this was with Jorge, our doctor. So is there a representative from group number 1? Feel free to take yourself off, put your camera on and take your mute off. Anyone from breakout session number 1?
They have very interesting opinions. So.
Oh, I was hoping Jennifer would talk. Jennifer? I guess we were saying that it is too early to diagnose, right? I mean, there's not enough data at all. Absolutely, we don't believe he has a histrionic personality. We do not believe he's depressed. And we were thinking, why don't we just talk to him? Find out, hey, what's happening? Why are you like so emotional, right? Start there is what we were saying.
Sorry about that. I didn't realize we were number 1. But you said it perfectly. And we also discussed the poor guy has been through a whole lot to get there to begin with. Use emotions, ask if he's okay, instead of just saying basically suck it up, buttercup, and I don't know, just handling it extremely wrong, in my opinion, our opinion.
I was thinking of maybe offering him some therapy, supportive therapy, to see if there's anything going on in his life that is adding a stressor, but not definitely not mandatory, but I think it would help him.
Thank you. How about someone from group number 2? There is a spokesperson for group number 2.
Is that for scenario number 2?
No, it was group breakout session number 2, breakout room number 2.
Oh, okay, sorry.
So Dr. Momenti helped to facilitate our group number 2's conversation. And I think we were all in agreement with kind of what group number 1 said, where it is too early to project a diagnosis onto Jorge, but that adding or offering a space for a check-in, whether that be supervision or potentially psychotherapy to support anybody that's in residency with any kind of like additional components that reflect his transition from a Hispanic-based medical school to Pennsylvania.
Thank you. For time purposes, I am going to ask Dr. Gracia if there's anything that he wanted to add regarding this case scenario.
Well, those are very good observations. And yes, I think it was too early to diagnose. I have to self-reveal. I'm Jorge. That was actually a case based on my own personal experience. And when I tell you what happened, that's important. That's, I think, the message, how important it is not to think that because somebody's Hispanic, it's one thing or the other. Even though I insisted that I was not depressed, they still gave me the weekend off because they thought I was depressed. I came back the following week, still tears coming down my eyes, still explaining I didn't know what was going on. They sent me to the eye doctor. I had Haemophilus influenza conjunctivitis that was traced back to a client that had Haemophilus influenza pneumonia that was under my care. So that was the explanation for that. It wasn't depression, it wasn't sadness, it was just a conjunctivitis. But again, because the idea that, well, this is a Hispanic person that is coming from somewhere, that must be a sign of depression, he's being emotional and that kind of thing, which was not the case at all. And in terms of the part about the being histrionic, I think it was funny because a person that was referred looked and said, he's not histrionic, he's Puerto Rican. And that's, you know, how we communicate, like Dr. Malmenti was saying, we use our hands very often. And, you know, it reminds me of a time that I had somebody come to Puerto Rico and ask me, why are people fighting in the bus? And I said, they're not fighting, that's, you know, they're talking. And sometimes when we engage in conversation, we get a little loud and we, you know, wave our hands and things like that, but that doesn't mean that people are fighting or it's a sign of emotional. So I think it's important that, yes, we know these things in the culture, but it doesn't mean that everyone has the same experience or behaves in the same way.
Very good, thank you. All right, I'm going to jump to case scenario number 2. And Matt, sounds like that was the case scenario that you were a part of. Is that correct?
Yeah, our group number 3, I think that was us, yeah. Lynn and I agreed to share the reporting back duties, but only because I nominated her. So then I had to agree to do it myself. So what I recall regarding our scenario was the 14-year-old coming with his parents. We thought it would be important to pay attention to what the immigration experience was like. Was it was it pleasant, you know, coming through on a plane and then, you know, coming through an airport and sort of a pleasant experience like that? Or was it one where there was a lot of stressors, overland travel? That would be important to pay attention to. It would be important to keep in mind the tension between the child being the interpreter for the parents, and then being mindful of the reality that in a lot of in some Hispanic cultures, it's not appropriate or not seen as appropriate for children to speak before adults or for adults. And so there may be some tension there. What else, Lynn? What am I forgetting?
Yeah, I think it was that. And then if a 14-year-old then is almost, you know, has to be the translator for the parents, then how does that kind of shift the dynamic of a young adult being in an adult role? And I think people mentioned about the family, you know, where it's not the young adult alone. the young adult is part of a family grouping, and then, you know, what's the role with the parents? And I guess not being quick to necessarily pathologize. We mentioned that we didn't, you know, we weren't given any details on what brought the young adult to services. It was just said behaviors, but being careful to not make judgments about what that could potentially be. Yeah, I just saw in the chat, children should never be used as the interpreter. Yeah.
Yeah.
Thank you. How about breakout session number 8?
That was the group I was in, and we talked about some of what Lynn said, but to add is really kind of get an understanding as to, you know, what got him there, what got him to the hospital. Is it behaviors that, you know, the family felt that he was you know, escalating, or was it the school? Because we assumed it was the school. Or, you know, did they talk with the parents? You know, how much of that came from the parents? And if they did, and if they want services, then let's start peeling the onion with this family and see what their needs are, and not make assumptions about this family, not both linguistically, but also culturally, because you do have a family that's from Nicaragua. And like I shared, I'm Puerto Rican. I know my culture, but I don't know Nicaraguan culture. So really kind of peel back that onion, get to know the family, get to know what their needs are, and how is DMH going to provide those services if needed. And really get the hospital on board too, as to what they see, get it back to the family by the parents, not with the 14-year-old. Because I agree, we didn't talk about that, but that was something that when you said we shouldn't be using the children as translators or interpreters.
Thank you, Alicia. Dr. Garcia, any final comments on the case scenario?
Yeah, I think those points are very valid about the being used as translation, etc. But I think one of the points also that we were talking about a little bit was the issue about path of immigration, what a difference, and you know, they mentioned, was it a smooth transition coming through an airport, or were they traveling through Central America in order to get here? Because that can have an impact also on how that young man would be behaving.
Very good, thank you.
I think too, just the stress of being a 14-year-old adolescent, probably, you know, assimilating into another culture and school, and some pressure from peers, and having to interpret for your parents. That's like a lot of anxiety that would come up there too. But then, you know, does his behavior reflect, like, you know, everybody was talking about some things that might have happened before they came, during.
Thank you. All right, I'm going to bring up the PowerPoint again. We have a few more slides focusing on strategies to support engagement, care, and treatment.
So it's a good summary in terms of what we have been talking about. And the first one that I want to bring is, again, keep an open mind. The Hispanic community is quite diverse. Our experiences are not all the same. Even though I had that experience myself being here, I also worked with, in my internship, in those rounds, there was a second generation Mexican immigrant resident with us. And of course, his behavior was very different than mine because he had been born and raised in this country. And I think that, again, you know, that is one of those things that contribute to people having these ideas. You know, we want to put everything in boxes. Well, they're both Hispanic. Why isn't one behaving different than the other? Because the circumstances are different. And that's why we need to keep an open mind at all times. Another strategy that is important is have patience and humility. It's okay to say to someone, I do not know your culture. I want to learn about it. Please teach me. And that helps us also know the person better, understand what their needs are. It's important, you heard that phrase, personalismo. I think it's very important to build that trust. I think in the Hispanic community, as well as with other people, but again, it's very important to also welcome the aspect of the culture so they can feel they can build that trust. Again, the cultural humility, understanding the Hispanic culture. I think that you saw in that video very interesting when she said, well, in the first example, when she says she's not speaks Spanish, but it's not from Spain. And he says, oh, yo veo. And she goes, don't, which is, I think, very interesting. Part of the humility is really being open to understanding. We don't have to, sometimes I see it on television, people trying to speak Spanish so that they can appeal to the community, but they are not speaking proper Spanish. So that is actually having the opposite effect. Consider the historical and cultural aspects when you do diagnostic assessments and clinical formulations, as we showed on that slide, for example, from the DSM-5, how important it is to take these things before we make a diagnosis, how important it is to consider those elements in making the formulations. We also want to improve knowledge of the country of origin of the client. I have a client, for example, that is from Ecuador. And I asked, well, where in Ecuador are you from? And he told me, and we looked at the map together on Google Maps, and so opened the door there to discuss about the culture, his background, etc., which, even though I'm Hispanic, is very different than mine. So that helps also establish that rapport with the client. Also understand the similarities and cultural differences. I think, again, as I was saying, that, it is sometimes people have the idea that because it's Hispanic, everybody's the same. But one example I would give you about that is the difference about Cubans and Puerto Ricans in Florida. Cubans were trying to escape communism, and a lot of them have ideas that are different than the Puerto Rican people that went there escaping hurricanes. They're two different things, and they have different effects on how people think about things. So those are even though they come from similar cultures, Hispanic background, their experiences can be different. And on the next slide, we have other suggestions, like, it's important to explore the cultural biases and the stigmas in a supportive manner, and provide education. Yes, we understand cultural biases happen. It has happened even to me. And this was just going to a record store, and somebody, it was an interesting experience, but there are biases and there are stigmas, and they exist, and it's okay, and we can approach them, and we can educate people on how to overcome them. Increase access to bilingual cultural staff. I think that's very important. I have clients that are very uncomfortable speaking in English, and we conduct our sessions in Spanish, and that's okay. Also partnering with the interpreters. If possible, use the same interpreter when available. I think this is something that helps the clients feel more comfortable too. Including family members in care. Again, we need to look at this in an individualized manner because, for example, a first generation immigrant may be more willing to include the family in the care. Somebody that is second and third generation may not be that willing. And we need to take those things into account. Again, look at each case individually. Incorporating natural supports when available, and these supports can be community groups, even church is very important, and engaging them. For example, in Puerto Rico, I did talk to a priest and talking to them about mental health issues and how important it is to recognize. And, we had a very good discussion about this because they're a great resource. And a lot of people will go to church when they're having problems, and it's important for them to partner with us to offer help to our clients. Having educational treatment and materials in Spanish, it's very important too. Many times people feel very uncomfortable filling applications in a different language. I had a client from Puerto Rico that was trying to get his birth certificate, and they printed for him the application in English. which she was very uncomfortable. And all you have to do is go to the internet, and they have it in Spanish too. So we were able to do that. Collaborate again with the resources in the community and engage with primary care and health clinics. For us in mental health, one of the things is that a lot of times we are not the first people that are approached when someone has mental health problems. A lot of our clients, Hispanic and non-Hispanic, are much more comfortable with their primary care providers telling them when they have problems. So for the primary care providers to know that we are here as a resource is very important.
Very good, thank you.
You're welcome.
So at this time, I'm going to turn it over to Jeannie Crespi. We've been doing a lot of talking today. We want to give everyone an opportunity to ask some questions, maybe that have come up during the presentation, or perhaps you came to today's training with a few questions. And we also have a few questions that we have prepared for today's presentation. So Jonathan, if you want to pin Jeannie Crespi, and also like to invite Alicia Colon. She's also going to be part of the panel. So yeah, thank you very much. While we have a moment, do you want to introduce yourself and share a little bit about your work with the REI and how we came to be? Because we are coming to the end of Hispanic Heritage Month, and you have been instrumental in the work that that committee has done. So I invite you to just take a moment and share some of the work you.
Totally unprepared, so thanks, Stephanie, for putting me on the spotlight. But my name is Alicia Colon. I'm the Assistant Program Director for the Area on Grounds program, and I've worked for DMH now for 18 years. I became part of the REI committee last year around September. At the time, Buddy had asked a few months earlier to get people from diverse backgrounds to join in the committee to really work on REI. And I became a part of it, and we started doing. I was part of the Juneteenth, and I had, along with myself and Melissa Costa, who I'm not sure she's here today, wanted to really highlight Hispanic Heritage Month because it's not highlighted. And I'm Puerto Rican. I was born in the States, but I consider myself Puerto Rican. And I know people will like, well, you're American, but I'm Puerto Rican. And I think other Puerto Ricans would understand that. And it's a hard concept to really explain when, folks ask me what I am. One, don't ask what I am. That's inappropriate. But two, I consider myself Puerto Rican. And I think it's a very important part of my work because I take both language and the cultural piece, important parts of the work. I've said it before, just because I speak language doesn't mean that my culture is the same as somebody from Nicaragua, somebody who's Cuban, somebody who's Dominican, somebody who's from Venezuela. So I think a lot of the times when I've been asked either to interpret or give my feedback, the response I give is really ask the family, ask the person, what's their culture? What do they believe in terms of like the mental health piece? Maybe they don't really believe in the American side of mental health, but really ask that person, ask the family, ask the identified client. Sorry, that was my son. It's a really, because we are family focused, and I know we're all about person centered, but in the Hispanic community, family is very important to us. So you want to get everybody involved, but you also want to ask them like what they see as the problem, what they see is they need help is, what type of services they're looking for, versus somebody from the outside saying, well, you need this, you need that. That might not work for this family. That might not work for the individual person. So really kind of asking the family, what they see as the problem, what kind of interventions they want to see, what's out there, and how is society going to provide these services. A lot of the times, I'll give you a quick example. When I worked in eligibility a few years ago, the kid didn't speak English. He just spoke Spanish. And I had a provider in the community say, well, we can't service him because he doesn't speak English. And I said, well, you need to figure it out because it's your responsibility. I don't know how you're going to figure it out, but it's your responsibility. You have the contract, figure it out. unfortunately, a lot of Hispanics in the community don't go to clinics, to mental health clinics, because they don't see others like themselves. So they're not sure if they're going to get services. And a lot of the times, you know, if you just speak Spanish, they kind of just dismiss you, unfortunately. And I think we need, as a whole, to really, when we do in the interviews, when we're doing the assessment, is to really get a big picture and stop peeling back the onion, to really get a grasp of what type of services they're looking for, what type of interventions we can provide. And I think that's it for me, because I'm like dying over here.
Thank you. Can you share your thoughts on, you know, holistic medicine, complementary medicine, home remedies that may be used by a patient, and, you know, your thoughts how that can be incorporated in care, and your thoughts, and perhaps even your own personal experience?
Yeah, well, depending on the culture, I think it's interesting that in some places, they're more likely to use home remedies, and some of them actually are helpful. And as long as it's not something harmful or something that may interfere with the treatments that we provide for the client, it's something that we can incorporate in their treatment. I mean, for example, this family has the habit of, for sleep, using warm milk with a teaspoon of sugar and vanilla. Well, that is innocuous and it's okay. And there had been some research into how that promotes sleep, because the milk contains tryptophan, the vanilla is calming, and the sugar induces release of insulin, which helps us fall asleep. So that's something that if they want to incorporate that, that's fine. Again, some Hispanic people have that custom of doing that. I think we need, as providers, to do the research on some of these things and make sure that they are not harmful, and then they are not going to be interfering with the treatments we provide. But again, it's preferences people have, and I always explore with them if they feel comfortable doing that. And, you know, they have, oh, I'm taking this or using this because that's what we do in my country. Well, that's okay. Another thing we have to keep in mind too is that if they're coming from another country, they may be receiving treatments that are not available here. Our pharmaceutical industry, it's not worldwide, and in other places they might have agents available that may work better for them, and then it's up to us again to explore what they are. Right now, lucky for us, we have internet, so it's very easy to find about these other treatments and see if we can find comparable things. But again, do it respectfully and understand that this is what is working for them, and that's okay. Just because it's not something we have in our country, it doesn't mean that it's something we're going to say it's not okay for them.
Very good, thank you. Again, I invite folks to, if you have any questions, to put them in the chat.
I've got one.
Oh, okay, thank you, Jonathan.
What cultural knowledge should clinicians have when treating a patient from the Hispanic community?
I think that's what we're trying to do today, have a general knowledge that their language may be different, that they may be from diverse racial backgrounds, that they may not see themselves as being different. That's something that is interesting. I think sometimes over here we think of people as, well, they're a minority. If you come from a country where everybody's like you, you're not a minority. And that concept of being a minority is something that has implications for treatment too. So understanding these experiences and where people are seeing themselves, and this is, again, a very important point. For example, I can see it in my own family. I had to think about that concept of minority because I came here as an adult. I have cousins that grew up in New York, and they see themselves as a minority. So in our conversations about things, it's important to take that into account because, again, how they may see certain issues might be different. So I think in terms of knowing about the culture is having the general idea. Again, most important thing is humility. know that Hispanic people are, again, very proud of their culture. I think Alicia's point is saying, yeah, we as a group, even if you're born here, but your parents are Puerto Rican, you consider yourself Puerto Rican. And same things with Mexican, Nicaraguans, and, you know, exploring where people feel their identities is what's going to be important.
Very good. Thank you. And Jonathan, did I see another question come up?
I don't think so, not in the chat anyway.
Okay. All right, I have one more. And this is what we have been talking about. How can we improve the cultural competency within our organization that can help shape the health outcomes of the underserved populations, specific to those projected numbers we're anticipating?
Well, I think as an agency, it's important to consider the community that we serve, the diversity that we probably want to have in our staff, so that we can be more effective in attracting and maintaining people engaged in treatment.
Very good. Thank you. So if questions continue to come up, please feel free to put them in the chat. We are coming to the end of our presentation, so we do want to just take a moment to do an evaluation. I'm also going, so on your screen, you see a QR code. You can scan your phone or device, and that will bring you to the evaluation. Also, I'll be putting that in the chat. So we do ask that you take a moment to do the evaluation. Thank you, Dr. Gracia, Dr. Momenti, Alicia, Jeannie Crespi, who has been working so hard the last couple of weeks behind the scenes for all of her work. Also like to thank Michelle Cormier from Central Office and Jonathan Fox, who have assisted. In honor of Hispanic Heritage Month, one of the things that we wanted to do was put a playlist together. And so on your screen, you see the QR codes. You can download this Hispanic Heritage playlist for both Spotify and Apple Music. So shout out to Michelle for putting that together. We'll be sending out the PowerPoint. We'll also be sending out these QR codes. As our facilitators talked about today, we do have references, quite a few. We will include that information in the in our final email to everybody with the PowerPoint. So again, thank you all for being with us here today. I hope you enjoyed today's presentation and walked away with a few new tools for your toolbox. Have a great weekend. Thanks again. Take care.